A, fif- a 52-year-old woman underwent total abdominal hysterectomy 3 years ago for benign disease. She now complains of hot flushes, night sweats, and vaginal dryness. What is the most appropriate treatment? Combined estrogen, progesterone, HRT, tibolone, oral calcium therapy only, SSRIs, estrogen only, HRT. Sir, option D, SSRI.
Oh, here she has got hot flushes, night sweats, vaginal dryness, and there is no other history which is given that will suggest us any particular drug is contraindicated. Okay,
Hmm.
mainly hot flushes, night sweats are there, and uterus is removed. So there is no role of progesterone. Okay, so what we can give is a estrogen only, HRT we can give. Okay, because there is no other history which they have given specific that where the estrogen will be contraindicated. Okay. So estrogen only HRT. Women who have undergone hysterectomy do not require progesterone as there is no endometrium at risk of hyperplasia or carcinoma. So estrogen only HRT effectively relieves vasomotor symptoms, improves vaginal dryness, reduces osteoporotic risk. Combined HRT is used when the uterus is intact. Next.
A 68-year-old woman presents with recurrent postmenopausal bleeding. She has a BMI of 23 kg per meter square and no significant medical history. Ultrasound shows an ET of 4 mm. Pupil biopsy reveals neoplastic tissue. What is the most likely diagnosis? Gliomyoma, endometrial hypoplasia, endometrial polyp, metroid carcinoma, serous carcinoma. Sir, option D, endometrioid carcinoma.
So here they have given serous carcinoma. Typically occurs in older postmenopausal women, is not strongly associated with obesity or hyperestrogenism, may occur despite minimal endometrial thickening. It is an aggressive type 2 endometrial carcinoma. Okay. So this is also one of the, but what you said was also correct actually. But with respect to these specific feature, they were expecting the answer. Okay.
Yes, sir.
Next.
A nulliparous woman at 41 weeks of gestation. A nulliparous woman at 41 weeks of gestation presents with spontaneous rupture of membrane. Cervical dilatation remains at 3 centimeter over 8 hours despite regular contraction. What is the most appropriate management? Administer prostaglandin vaginally, C-section, commence intravenous oxytocin, membrane sweep, repeat examination after 4 hours. So C-section.
Here comments IV oxytocin. This patient demonstrates delay in the first stage of labor. So 8 hours are passed. So 2 times actually the PV is done. So membranes are already ruptured. Contractions are inadequate for cervical progress. So oxytocin augmentation is indicated. Next.
Which description best applies to polygalactin sutures? Which description best applies to polygalactin sutures? Braided, absorbable, synthetic, braided, non-absorbable and synthetic, non-braided, absorbable and natural, non-braided, absorbable and synthetic, non-braided, non-absorbable and natural. Uh, sir, option A,
Polygalactin.
braided, absorbable and
Yes, it is
synthetic.
braided, absorbable, and synthetic. Okay, Vicryl. Polygalactin 910 is synthetic, absorbable, and braided for not security. It is commonly used in obstetric and gynecological surgery. Next.
A 15-year-old girl requests contraception advice. She has history of thromboembolism and multiple recent sexual partners. Which legal principle specifically applies to provision of contraception in minors?
Yes,
Abortion Act 1967, Bolam Principle, Bolitho Principle, Fraser Guidelines, Gillick Competence.
this is
Hmm.
also expected question.
Read this, sir. Actually, I have not read this.
Yeah, actually, part two syllabus is more involves the clinical governance. Uh, it is contraception is a Fraser's guideline, and Gillick is for termination. Remember, Fraser for contraception and Gillick for termination. Okay, when you are dealing with teenagers. Okay, so if we are talking about contraception, always select the Fraser. Okay, so Fraser guidelines specifically relate to the contraceptive advice and treatment in individuals under 16 years. They assess maturity, understanding, and best interest. Next.
A woman with one previous cesarean section presents in spontaneous labor at term. She is 6 centimeter dilated with regular contractions. Okay, what is the most appropriate initial intrapartum management? Immediate fetal blood sampling, continuous fetal monitoring with oxytocin infusion, continuous fetal monitoring, and repeat vaginal assessment after 2 hours, intermittent auscultation, and early examination encourage mobilization only. Sir, level with regular contraction at 6 centimeters. Sir, continuous fetal monitoring with pitocin infusion. Option B.
Previous LSS, are we going to augment
No,
with
no, I
oxytocin?
repeat, no, sir. Option C.
Yeah, but still I do not agree with PV after 2 hours because
2 hours.
PV is every 4 hours. Okay. So women undergoing VBAC requires continuous electronic fetal monitoring, close labor progress assessment, and because of the risk of uterine scar rupture. Next.
Yes. A woman with previous cesarean section develops sudden fetal bradycardia. Previous C-section develops sudden fetal bradycardia and cessation of contractions during labor. What is the most likely cessation of contraction and sudden fetal bradycardia? What is the most likely diagnosis? Placental abruption, scar dehiscence, scar rupture, tetanic contraction, uterine atony. Sir, scar dehiscence.
There is a fetal bradycardia and cessation of contraction. So there is going to be scar rupture. Features suggestive of uterine rupture will include fetal bradycardia, sudden cessation of contractions, maternal pain, scar tenderness. It is an obstetric emergency. Sorry. Next.
Operative vaginal delivery during vacuum assisted delivery, where should the ventouse cup should be placed? Um, the rest are incorrect. No.
Few answers are
The
given
here.
here. So first is a locate the flexion point. Apply the cup to the flexion point. Push the cup under the head of the fetus. The required distance to reach the flexion point, that is 5 centimeter in front of anterior positions, okay, or 10 centimeter for the posterior position. Okay. Then create vacuum and apply traction only during contraction in conjunction with the maternal pushing efforts. Okay. Flexion or a pivot point is there, so that you have to locate. Okay, so here it is in front of the posterior fontanelle, is around 6 centimeters, 60 millimeter mercury. So this is the flexion you have to apply to the flexion point. This is the anterior fontanelle, this is the posterior. So in front of the posterior fontanelle, okay, you will apply this vacuum.
Okay.
So correct answer is 3 centimeter anterior to the posterior fontanelle on sagittal suture. Okay. Correct placement at the flexion point promotes flexion, minimizes the cup detachment, and improves the success of the operative vaginal delivery. So flexion point you should remember. Next, that is a 3 centimeter anterior to the posterior fontanelle. Okay, on the sagittal suture. Next.
Perineal trauma, a woman sustains a perineal tear involving approximately 60% of the external anal sphincter. The internal alar sphincter and the rectal mucosa intact. 60% 3B tears. Option C.
Yes. Because it is more than 50%. Okay. So it is a 3B tier. So 3A less than 50% external anal, more than 50% external anal, 3B, 3C is external plus internal, 4 degrees of anal mucosa. Next.
Ovarian malignancy most commonly drains initially to which lymph nodes? External iliac, hypogastric, inguinal lymph nodes, internal iliac lymph nodes, para-aortic lymph nodes. Actually, ovarian drains to para-aortic nodes.
This goes to the para-aortic group of lymph nodes. The ovaries originate embryologically in the upper abdomen and therefore primarily drain to the para-aortic lymph nodes. Next.
A pregnant woman following IVF presents with severe unilateral abdominal pain. Severe unilateral abdominal pain. Ultrasound shows an empty uterus and beta HCG 5,500 international unit per liter. What is the most appropriate management? Repeat beta HCG in 48 hours. Laparoscopy with salpingectomy. If ectopic pregnancy is confirmed. Laparoscopy with salpingotomy. Methotrexate therapy. Repeat scan in 7 days. So laparoscopy with salpingectomy. Actually, it is salpingectopic pregnancy. Yes, sir.
It is going to be a laparoscopy with salpingectomy if ectopic pregnancy is confirmed. If symptomatic ectopic pregnancy with high beta HCG, IVF conception, significant pain, surgical management is usually preferred. Next.
A pathological CTG is noted during labor. Okay. Fetal blood sampling reveals pH of 7.2. Acidosis. What is the next step? Immediate delivery. Reassure patient. Repeat fetal blood sampling after 1 hour. We repeat FBS is if abnormalities persist. Repeat FBS within 30 minutes. Sir, immediate delivery.
Because it is a pathological CTG, you have to expedite the birth. But as per actually FBS, this is changed. This guideline is changed. FBS role is very limited, so we'll skip this. Okay. Next.
An elderly woman presents with cold intolerance, weight gain elevated to prolactin levels. Okay. What is the most likely cause? Antiemetic use, hypothyroidism, neuroleptic use, prolactinoma, renal failure. Actually, cold intolerance and weight gain goes with the elderly woman. Prolactinoma, sir. Option D. And hypothyroidism also.
Option is answer is hypothyroidism, because primary hypothyroidism increases TRS secretion, stimulates prolactin release, may cause hyperprolactinemia. Next.
A post-operative patient develops hyponatremia after hysterectomy. She received large volumes of IV fluids. Which fluid is the most likely cause? Excess IV dextrose, diabetes insipidus, primary aldosteronism, diabetes mellitus, ureteric injury. Which fluid is the most likely cause? And the
Which hormone it is related to?
aldosterone. Primary option C.
Excessive IV dextrose, 5% dextrose behaves as free water after glucose metabolism and can cause dilutional hyponatremia. That is one, but still it can be inappropriate ADS secretion also. That is not given. Next.
A woman with
Sorry.
A woman with 2 previous C-section presents at 35 weeks with painless vaginal bleeding and transverse lie. What is the most likely diagnosis? Placenta, bladder.
So the placenta is shown. Here is the placenta. Okay, here is the bladder. So you will be given either UHG image or maybe diagrammatic also. See, here you can see the placenta. This is the canal. This is the cervix. Okay.
Okay.
So what could be the diagnosis in this case? She is a previous to LSS with painless vaginal bleeding. And this is the image.
Painless, no? Placenta previous, sir.
It is going to be placenta previa. So classic feature is a painless bleeding, previous cesarean section, transverse slice. Strongly suggest placenta previa. Okay.
Yes.
So that finishes the today's session on the mixed bag. Thank you.